So we have a full house here today, and we have the wonderful attendance from people from all over Boston, as well as the university. And I'm going to hand off our introduction role to the dean of the Pardee School of Global Studies, who's here, Scott Taylor. Thank you
Great.
so much.
So I feel like it was going to be a little odd to introduce Professor Yi Dionne to this group since you've already met her and know her. But to those online, I feel like this is more to the online audience. And this is welcome back to the Pardee Center. This is one of the first sessions and second one in several months. It went through a bit of a rehab after a recent flood. So delighted you all could be here. Thank you, Professor Heine, for hosting us here, and Professor Harris for the seminar. So I want to introduce Professor Yi Dionne, who's Associate Professor of Political Science at UC Riverside, for her talk this afternoon on money and medicine in Malawi, linking state health spending to health outcomes. So looking forward to that talk. She's Associate Professor at UC Riverside and was awarded Professor of the Year in 2022. Her research examines health interventions, politics, and public opinion, primarily in African countries and with a particular focus on Malawi. She received her PhD in political science at UCLA, where she received a FLAS fellowship and was later a Fulbright scholar in Malawi. Prior to her appointment at UC Riverside, she held appointments at Smith about 13 years after I was there. But we have many friends on the faculty still in common, and they spoke so highly of you, at the time and continue to. And then before that at Texas A&M University, where she had her first appointment. She's published widely in political science and health journals, including Electoral Studies, World Development, and a number of health and related fields. She's the author of the book, Doomed Interventions, The Failure of Global Responses to AIDS in Africa, published by Cambridge in 2018. And as you heard, and many of you, except those of you who are dragged here, know, she blogs and podcasts and engages in a host of activities that are way too cool for most political scientists. But I'm delighted that she does. They reach a wide audience.
You get that thing that she plays cool music.
And plays cool music, yeah. And plays cool.
She posts about the classes, always thinking.
You know, you're the envy of us all. But we're delighted to welcome you here this afternoon. Thanks for being at BU and at the Pardee School and here at the Pardee Center and for the seminar. Thanks.
So thank you all for coming in person and online. So grateful that you're here. And I really want to thank Joe Harris for inviting me to give this talk, and the Pardee School and the Pardee Center for hosting it, and for all of the co-hosts. I saw on the flyer, it looks like you wrangled quite a few people, the Department of Political Science, the African Studies Center, the Comparative Politics working group. I probably got that wrong. And all of the others who supported this event and my visit. There's nothing better than New England in October, so I'm really glad to be here. So this talk is going to start with a few big questions and caveats. So let me just air one first. Apologies in advance if you came for some answers, because this is really a talk about questions. I'm starting a new book project about social exclusion and how state and social exclusion, what that means for health outcomes, and in particular looking at three of the leading pandemics in Africa. So that's HIV/AIDS, Ebola, and COVID-19. But I'm currently in the question phase and not in the answer phase. So let's start then with the question that's driving this talk, and that is, does it matter how much government spend on health? Now, my broader research question, I think throughout my research agenda, has been focused on the politics of providing health services, especially in the context of infectious disease pandemics. And I'm interested in understanding the politics that shape how state interventions translate into health outcomes. And so, the kind of bigger question that I've been asking in much of my work is, how can politics shape health outcomes? So I'm actually really grateful for this workshop's existence. And by this workshop, I mean the Global Health Politics Workshop. And this is the 3rd year now of its existence. And so for all of you online, I'm usually one of you in the Zoom room, saying hello to new people I haven't met before. This is my first time actually being at the Global Health Politics Workshop in person. And this workshop means a lot to me because when I was a graduate student, in the early part of my career, even actually when I was an assistant professor, I wondered where I belonged in political science. And in fact, a lot of senior political scientists asked me if what I even did was political science. So not being able to find my place, it was really great to meet other scholars who did global health politics and to learn that the things we were studying were important, and that we could bring our training as social scientists to bear on these questions that we thought were really important. So I want to talk a little bit about why and how I study global health. So first, we kind of were joking like, oh, Kim blogs and she does podcasts, and the reason why I do those things is because I think it's really important for political science to not be gate kept in the ivory towers of the academy. Like, I think it's really important that we have a lot of knowledge, and much of that can be translated in ways that are helpful for other people to learn from. And so that's part of that is part of this broader commitment I have to doing work that matters. And for me, health is a really easy thing that we can say matters, right? I believe that we should all, regardless of the lottery of our birth, should have an equal chance at living a good, long life. And so because of that, I study health. I think that there's other things that I could study that would be consistent with that normative commitment. And I think, lots of academics study things that matter to them, and health is the thing that matters to me. And when I was a first year PhD student, just to kind of tell you how I even got involved in health in particular, I went to graduate school thinking that I was going to study ethnic conflict. I was certain I had read all this cool stuff and that's what I was going to do. And I go to a workshop kind of like this. I mean, literally there were about this many people in the room, and a political scientist who studies Africa, Jennifer Widener, she was this keynote fancy person we brought from, I don't remember if she was at Harvard or Princeton at the time. She was at one of them. And I was just this first year grad student thinking, wow, this smart person. And as we go around the room and we all talk about what we're studying, another question we had to answer was, what do you think is a future area of political science that's going to be a growth area, an area where people are going to study? And she said, a lot of us study conflict and wars. More people die of AIDS. How come we're not studying that? Now, of course, at the time, Evan Lieberman was writing his book on, and so some of us were studying it. And of course, Amy Patterson, who's at Sewanee, the University of the South, there are some political scientists doing it. But back then, this is in the dark ages, 20 years ago, when I went to graduate school, there weren't people doing it, right? There was, I think, Kathy Boone had worked with an undergrad to write this short article encouraging people to do it. But I took that as an opportunity to study something that wasn't conflict, but to do it in a way that drew on my political science training. So, a lot of the things that I've read are informed by political science. And the way I approach questions are, it's kind of baked into how I was taught how to do methods, so that's my approach to it. That's not the only way to attack a problem, but that's the way that I know best. And at the same time, it was because of that loneliness in graduate school, where I was the only person who was doing this, that I started reading in other disciplines and learning from those other disciplines. And so I try to honor the things that I've learned from those other disciplines, and the approaches and the methods that they use, though I acknowledge, that's not what I'm trained in, and maybe sometimes I get it wrong. And I'm really good at telling people, when I'm good at learning in public. Let me put it that way. I get things wrong, and that's okay because I have a growth mindset. And as long as I'm learning and growing from it, it's okay. Also, what's been really important to me, especially as a person who is not from the continent, as a person who studies politics in Africa, it's really important to me to try and decenter myself from thinking about what's important and what are potential solutions to the problems that people are facing. And so I feel very fortunate in that the time that I was coming up as a political scientist, there was this really cool, new, neat thing, which is now actually quite old. That's the Afrobarometer, which is a Pan-African research network that collects nationally representative surveys in 36 African countries. And it's because of that that we actually, all of us, as long as we have access to the internet, we can actually see for ourselves what Africans prioritize, what their ideas are about governance and markets. And so, thankfully, I think being trained during that time, it's made it easier for me to not focus so much on what I think and really kind of centering the experiences and insights of ordinary people. So I wrote a book. I don't love the title. I didn't pick it. So if you like the title, good for you. You're exactly who Cambridge wanted to market the book to. So the empirical data in that book, so that book focused on HIV/AIDS, and I started that as, that was a dissertation project that turned into a book. And the empirical data in doomed interventions focused a lot on ordinary people. And as much as I want to center their experiences and their insights, when I look back at the things I wrote in that book, I think it probably could have done a bit more to talk about the state and done a bit more to talk about the international political economic conditions that created the realities that Malawians and other Africans had to navigate the AIDS pandemic. Because the state and international political economic conditions largely structure and shape ordinary people's actions. So you may have additional critiques of my book. I welcome them. But this is the one thing that really bothers me about the book, is that I think that there's not enough of a focus on the state. And there's a reason why I think the state's important. And this may be more of a normative statement, though I'm, Weber's not alive, but I could fight him on what the state is and what it does. So as a political scientist, right, like I have to teach undergrads, like, what is the state? How do we define it? Like, what is the state? What isn't the state? And what should we expect of the state? So I don't think that I have an answer to that question yet. I think, every time I teach it, there's like I think a little bit more and a little bit differently about what the state is and what the state does. But today, right, 10/10/24, I'm thinking of the state as an entity that exists to coordinate individuals' behavior in the collective interest. And that's especially true when individuals' behavior, behavior that would maximize an individual's utility is in tension with the behavior that would yield better social outcomes. That's why the state is there, right? Because if it was just like us maximizing individual utility, like markets, you do great work, like, yay, climate change, we wouldn't have to worry about it because someone could just raise like some tax on fuel and like no more environmental degradation, right? There would be some answer. But I think this is why the state exists, is to coordinate our behavior for our collective interest. And so, you probably know this because you've lived through, you're all old enough to have lived through the COVID pandemic, right? Nobody here is a toddler that missed it. But one thing we learned from the COVID pandemic is that biomedical breakthroughs that bring us vaccines and treatments are necessary but insufficient in keeping us healthy. Kudos to, we were talking, for those of you in the Zoom room, we were talking earlier about the Moderna, the booster Moderna, and how it was like really someone, was like, oh, making me feel terrible. It's like, oh, I should have had the first two. I mean, please, if you haven't gotten your booster, please go get it. Everyone who can. I love that we have a vaccine to protect us from this highly infectious, debilitating condition, especially because of the challenges that come with COVID. The problem is not, I mean, it was so great how quickly we got those vaccines. And I have a paper with Karen Three, Boniface Dulani, Adam Harris, and Wei Shi, where we study vaccine hesitancy in Malawi. And, you know, it's through doing research for that paper and seeing vaccine hesitancy all around the world that really kind of gives me a lot of confidence in saying vaccines are not enough, right? Because there's lots of reasons why people won't take them. What we need are, you know, we need these biomedical researchers to find these vaccines, but we really need good social scientists who can think about what gets people to take them. I also was recently reading Peter Pio's memoir. So he was the first director of UN AIDS. He was also one of the scientists who went to the first known outbreak of Ebola in 1976 in what was then Zaire, today Democratic Republic of Congo, which was why I started reading the book, but it was so good that I just kept all the way through until the end. And actually towards the end of his memoir, he talks about a conversation that he had with Botswanan President Festus Mogae regarding voluntary medical male circumcision. And what President Mogae was saying was, you know, he was challenging Peter Pio to say, you guys found this silver bullet for AIDS, right? It's male circumcision. If everyone gets circumcised, it's not quite a vaccine, but there's, and we're not going to get into talking about cutting foreskins today. Sorry, that's what you came for. But there are reasons why it's protective against transmission of HIV. But what Festus Mogae was saying is, how come all of these programs that UNAIDS and others are promoting for voluntary medical male circumcision are geared towards teenagers and adults? Why don't we just do it from birth? More circumcision of newborn boys instead of only adolescent and adult men. And what he's asking us here is, how come you're not in it for the long haul, right? You're trying to do the quick fix. And well, I'll get to this in a minute. There's other work I've done which talks about why people will do things in the short run, but not in the long run. So again, talking about, saying some ground rules based on literature that's outside of political science. And historians Prince and Marsland study public health in Africa, and this is how they define or think about public health. It conventionally refers to the duties of the modern state concerning the protection and care of the health of its citizens, right? So it's this idea that, the state's required to take care of its citizens' health. Now they go on and say, of course, that's not been the case in Africa, right? Even if this is the standard, we're not seeing that in Africa. Okay, so with all those caveats aside, my goals for today is to just try to lay out the logic of government health spending. Why do governments spend on health? And then, to share some patterns in health spending based on existing data. And then, I don't know, I say I'm going to link health spending to health outcomes. I'm really not going to do that. I did try. So with various data sets that are available, it's just like nothing. There was enough missingness that I just don't feel comfortable presenting, I don't know, even like a graph, and someone takes a picture of that with their phone and it's like, no, she's talking about. So I'm not doing that. But I want to focus today's talk on Malawi. And maybe you're already familiar with Malawi because Madonna's adopted children are from there, so you know it for that reason. Or it's the home country of 4 of her adopted children. It's also the second African country to have a woman as president. Kate and I were talking about this earlier. It's the first place where a guy dies in office and the female vice president becomes president. Now, Tanzania, of course, with Samia leading the country after the death in office of their president, probably of COVID, by the way, in case anyone didn't know. They didn't have any cases, except he definitely had COVID. Heart failure due to COVID, exactly. So she came into office following the death in office of former President Bingu Mutharika, or maybe you know about Malawi because The Economist in 2020 called it the country of the year. And that's because they were celebrating the unprecedented overturn of the 2019 presidential election and this broad social movement for democracy that culminated in the 2020 election of this lovely man here, Reverend Lazarus Chakwera, the president. He was the opposition leader at the time, and this historic movement for democracy is what led The Economist to call it the country of the year. And I wrote a Journal of Democracy essay about how everyone could learn about protecting democracy if you just look at this little sliver of a country in southeastern Africa, pictured here, right? Big continent. I'm talking about this. If you see the blue part, that's the lake. It's the best part of there's lots of great parts of Malawi. I love the lake. Well, don't tell my friends who live in the north on Nika Plateau, but yes, I love the lake. It's one of the largest and deepest freshwater lakes in the world, and it accounts for about 1/5 of Malawi's total area. Now, the population of Malawi is, I think in 2023, was estimated to be about 20 million people. Population has grown a lot. When I first started studying Malawi in 2006, it was 14 million. So population growth is quite high. Women have lots of children, that's your wealth. And a lot of children die very young. So a lot of people have a lot of children not knowing whether their children will make it to adulthood. Malawi's economy is primarily agrarian. Oh, I should also say half of Malawians live below the national poverty line. This is a place where there's a richness in the lake, but that is not realized in a lot of people's everyday lives. The Afrobarometer found that half of the Malawians in its nationally representative sample reported not having enough food to eat within the last 12 months, either several times or many times. Likewise, Afrobarometer found that half of them went without necessary medical care several times or many times in the year before their survey. And these are according to 2022 data. So it's an agrarian economy where 80% of people rely on agriculture for their work. And so this is going to be important when thinking about if a government is spending on health, what are the other priorities it's going to have to consider? And okay, so here's another complaint about my own book. So I wrote a book on AIDS because I thought AIDS was really important, because I went to this workshop and Jennifer Widener was like, everyone, like, there's so many more people dying of AIDS than before. True statement. If you go to Malawi, as you see in the book, right, I tell the truth of like what the data say. If you go to Malawi, that's like the least of their concerns. Of the major concerns there are even more major concerns like food security. And so some of the work I did after the book, the guilt work, was focusing on the things that Malawians told me were more important, like food security. So what are the things that government's trying to do to actually make people more food secure? Okay, so why do governments spend on health? Like, do they have to, right? It's not like a law. Well, maybe in South Africa. Okay, but generally speaking, right, what are the reasons why governments spend on health? So now, in democratic contexts, right, when access to power is broader and more competitive, the exercise of power is more accountable and more likely to produce policy that benefits broader sectors of society. So we know this from I've just cited a few things that tell us this, right? That in democracies where there's competition, regimes will try to make social policies that benefit more and more people, because then maybe those people will vote for them in the next election, right? And I'm fairly convinced by that. But democracies don't make up all of the world, right? And even within democracies, there's variation. So there's this really neat paper, in Latin America, which looks at leftist parties. And when leftist parties are in power, they spend in ways that are consistent with what we would say are values among leftists, right? Equality and solidarity. And so they try to seek to reduce inequality through social services, right? And so we see this. We're not really seeing very many leftist parties in Africa, though, right? So that's not as much. We're also not seeing a lot of ideology among parties in Africa either. So again, not terribly helpful to us. And then, so to get back to what I was saying before about festus moge and like, why aren't we, offering voluntary medical male circumcision to babies, right? When little babies are born, as opposed to waiting until when they're adolescents and adults. The first thing I ever wrote about AIDS was saying it's because of time horizons. So if you're governing, you may not invest in something expensive like health unless it's going to benefit you. And it's not going to, health is such a long run investment. It doesn't benefit you unless you're going to be in power a really long time. So I gave this paper. It's my first presentation as a graduate student at a conference. I was so excited. I bought a blazer and I was ready. And I go and it's almost like I got booed off the stage because I had this graph up. I was so proud of my graph, because I had I used this, it was this new to me statistical program called R. And I thought it was so fancy because I knew how to use R and I made this beautiful graph. And, but it made South Africa look bad and it made Zimbabwe look good. And I was at an African studies conference and that was the opposite of what anyone wanted to hear. It was like, South Africa is good and Zimbabwe is bad. And South Africa is good because we have democracy there. And Zimbabwe is bad because that guy ruling is a dictator. And I was like, no, but see, here's the thing about dictators, right? Not saying I like them, but you do you. The thing about dictators is that if they are a dictator like Robert Mugabe, they really think they're going to be in power for a very long time. So what's interesting is Robert Mugabe thinking he's literally going to be in power until death, and he was doing yoga and drinking green tea to really make that long, long life. If you believe that, then something like HIV/AIDS, which takes 8 to 12 years to manifest in terms of its natural epidemiological history, if you think you're going to be in office 12 years from now, you're going to solve that problem, even though you're investing in a really long time horizon. But if you're South Africa and you're having these regular elections where there's there's not meaningful competition early on, but there's some competition, right? You may be more concerned about the pressing everyday concerns of citizens, right? And so I'm not saying dictators are good. I think that was the misunderstanding in that conference. I probably was not very good at articulating myself that day, but yeah, so some governments will spend on health because they have this long run interest. And for those of us who are small d Democrats in the room who like democracy, we should be concerned about that. What does it mean when you have these regular competitive elections? What will that mean for the actual quality provision of public services if we're always in competition and trying to win these hard-fought, narrowly won elections? I think about this a lot. Talking about Ghana earlier today, I was thinking about that paper that I wrote with Karen Greppen, where we talk about, one of the reasons why NHIS, the National Health Insurance Scheme, exists in Ghana. Same reason why Robin Harding and David Stasavage found, the expansion of public education in Ghana is because of that competition. Competition was so fierce between two major parties that they were like, well, what can we do to win voters? We can't just give to our party members. We need to give broadly so that we can win over people who might not have previously supported us. Okay, so now, so we have some ideas on why governments might spend on health. How much should they spend? So the Disease Control Priorities Project is an international collaboration of health experts from the University of Washington, the WHO, the World Bank, and other institutions. They estimated that an essential high priority healthcare package would cost at least $42 per capita annually in low income countries. So, they did this like trying to understand like what are the specific costs of a battery of life preserving health services, things like immunizations, against preventable diseases, rapid malaria tests, rapid HIV testing, labor and delivery services for pregnant people. And so, how much would it cost to provide those services to at least 80% of a country's population, and not just at like major hospitals, but also at community clinics and through community healthcare, like through community health workers, right? Like how much would it cost to get 80% of the population what they needed? And that's how they came up with $42 per capita per year. And so what do we see in Malawi? So here's health expenditure per capita over time between 2000 and 2022. This comes from the Global Health Expenditure Database, which is compiled by the World Health Organization. And you can see it's only the last 3 years that they've met this, this base requirement. We're not talking fancy stuff. We're not talking surgical theaters to get people necessary surgeries, right, to stay alive. We're talking like basic minimal requirements for health. Okay, maybe I should start with the good news. Good news, look, going up, right? More than quadrupled. We started about $9 in 2000 and we're $47, $42, $47 in 2021. So that's good, right? It's going up. Really significant, but it's not enough. And well, also it's going up and the population increase. So like, the amount overall that they're spending on health is higher. So that's all of those are good things. Okay, so that was the good news. Okay, who's spending it? Where's the money coming from? So this is again, more data from the Global Health Expenditure Database. So they have a lot of data on health expenditure, and this is all around the world. This is specifically in Malawi, but their data are all around the world. And I encourage you, if you're interested in this, to take a look at their data. One of the things I like to look at is where the money is coming from. So here, that dashed red line that's at the top, that's external financing. That's basically donors or let me call them bilateral partners, because sometimes that's actually loans and not aid. Whereas the government share of the financing has been decreasing over time. Right, so it used to be in 2000, the Malawian government spending on health accounted for 43% of the share of health spending, while external financing was only 37%. But then we see a switch and they're never going back. And a lot of this has to do actually with HIV/AIDS. So starting in 2004, 2005, we start to see the provision of antiretroviral drugs for people who are sick with AIDS. And that treatment, even though it was generic treatment, it was still quite expensive. And the funding and financing of that was largely through the Global Fund and PEPFAR, right? So a lot of HIV/AIDS interventions were actually externally funded and not internally funded. And so that's part of the reason why we see these roles reverse. And perpetually, I think we're going to see external financing to be the lion's share of funding for health. So remember from earlier when I share with you the context of Malawi, the government has competing priorities, right? If they're going to deal with something, is it going to be health or is it going to be the economy, right? Because they have this high poverty, they have a lot of people who don't have jobs. You know, it would be nice to invest in people's health, but we've got these other pressing concerns. People don't have work, people are underemployed. Also, people don't have enough food to eat. So many children in Malawi are stunted, right? They're short not because of, you know, their parents are short, they're short because they didn't get enough food to eat when they were growing, and so they didn't fully develop. And so, you know, if the government had funds, they have these other issues to consider. And on top of that, international financing of health follows bureaucratic budget expectations. So Malawi's government knows that donors are going to continue to spend on health. So if we know that PEPFAR is going to come through and pay for antiretroviral therapy, then we don't have to. And I'm going to tell you a little story. This is a picture of the U.S. Embassy in Malawi. When I was a Fulbright scholar in Malawi, finishing up my dissertation work, my dissertation fieldwork, I was leaving, but because I was a Fulbright scholar, they invited me to come and give a talk. Just tell us what you found. And I was like, well, I don't really know anything yet. Like, I could show some graphs, but I don't know. I feel more confused. Like, I feel like I know less having been here all this time. And they're like, well, just tell us what you have. And I was like, I just don't know, because all of the data say that Malawians don't prioritize AIDS. They prioritize everything else. And I was like, maybe I'm looking at it wrong. Maybe I need to do some robustness checks, you know? So I was doing all this stuff, but I was like, well, you know, there's no way I slice this data where that's not the story. That's what it is. So I go and I give this talk, and everyone in the room is in the development or health space, working for the US Embassy, USAID, or partners, right? Save the Children, whatever, name your favorite international NGO. They had some probably low-level staffer in the room, because it's like some idiot grad student in the field who doesn't know anything. So many of them were Americans. There were some Europeans. There were also Malawians, again, staff at these various organizations. And I was saying this, oh yeah, AIDS is not a priority. And the Malawians were like, yep. Like, they're not surprised at all, right? And the Americans were like, no, you know. And I share this on the budget slide, and I talk about bureaucratic budget. So anyone who's taken like an intro, you know, what do bureaucrats want? To maximize their budgets every single year. Because if you're a bureaucrat and you spend your whole budget, then the next year when they allocate, they have to give you what you got the previous year because you spent the whole thing, right? At the end of the year, this is why bureaucrats will like spend like crazy at the end of their budget year, because if they don't, then they're signaling that they didn't need that much money and you should give them less, right? So when I'm here at, you know, giving this talk, I'm like, yeah, you know, you should spend on other things, guys, like pick something else. And they were like, so, and the biggest thing that Malawians in these surveys said, they said, you know, what really we need is clean water. Please get us better access to clean water. And that was the number one priority. And number two was food, you know, food security, which is interesting because this was actually a banner year for food production. I was like, okay, food security, but they probably had a recent memory of famine, and so that's why they're talking about agricultural production and food security. So I'm in this room talking to these key decision makers, and I'm like, yeah, they really want you guys to spend on something else. And they were like, well, could we do a well project that's like branded with AIDS? And I was just like, what are you doing? Like, I just told you that's not what they want. And I was like, oh, you're a bureaucrat and you have to spend your budget, and your budget was allocated to spend on HIV/AIDS. and you're a person who cares about what people want. So you don't want to blindly spend on the thing that people have told you is not a priority. You actually want to do something that's helpful to people. So of course, I didn't get that until like I was back in the day. I was like, those idiots, like they weren't listening to me. And I was like, no, I wasn't listening to them. Actually, they did want to spend on the thing that people cared about, but their own incentives were to spend according to their allocations and to maximize the spending of those allocations. And so again, if you're the Malawian government, and you know that because US budgets are public information, right? You can find that out. Then there's no credible threat, right? That they're going to pull all of the funding that pays for everyone's HIV/AIDS drugs, right? So again, if you're a government, maybe you're not going to spend as much on health. If you have, if you are, for example, Malawi, which is heavily aid dependent. Okay, so knowing that, does it even matter? Right? To go back to that original question, like how much government spends on health. So there's in the literature, economists have been studying this for quite a while, right? Trying to understand. So Filmer and Pritchett have this older study from the last millennium, right? About the impact of public spending on health. And in their analysis, they show that impact is quite small. And in fact, these other things, the state's income, its distribution of income, the proportion of its female population that's educated, the extent to which there's ethnic and linguistic fractionalization, and the proportion of their population that is Muslim, that actually largely explains variation in child and infant mortality. So I say child and infant mortality because that's what a lot of us like cross-national data nerds, like that's what we use for health, right? So to understand health, we rely on these consistent indicators. I don't want to say reliable or credible because there's a lot of reasons why they're not good everywhere all the time, but they're measured the same in most places. So they use child and infant mortality to try to understand health. And what they say is, actually public health spending is not really moving the needle there. And in these economists, Mhango and Chirwa, they're both Malawian economists. They actually looked specifically in Malawi, and they find that increased health spending is actually associated with decreases in child mortality. So they actually do find that in Malawi, public health spending is good for health, is good for children's health, except if corruption is high. Then the more you spend, actually, it's associated with poorer outcomes on child mortality. And that is consistent with cross-national research that found higher corruption is associated with lower levels of health expenditure as a percentage of GDP with poor health outcomes. So corruption is a real problem. Again, Afrobarometer data, you can look at, the extent to which people pay bribes to access regular public services that are supposed to be free, including primary health care. So with that, I want to talk again about Malawi autocracy and corruption. Anyone know who this guy is? Anyone seen him before? Scott's nodding his head yes. He's studied. Okay, this is Bingu wa Mutharika, the second president, the late Dr. Ngozi Bingu wa Mutharika. Let me give him all of his honorifics. Not sure about that doctorate, but okay. So, but he was a World Bank economist. So Bingu wa Mutharika ruled Malawi from 2005 until his death in office in 2012. Anyone want to guess what he died of? Heart attack. He's an older guy. There's lots of juicy rumors that I won't say on the internet about what was happening when he had his heart attack. But he had a heart attack. Okay, so 2012. So Bingu wa Mutharika comes to office. So actually, he's elected into office in 2004, and he's elected under the United Democratic Front, so the party of his predecessor, Bakili Maluzi, the first president after the return of multi-party competition in Malawi in 1984. Maluzi tried to run for a third term. Very close, very narrowly had a chance, didn't get to, picks this totally obscure guy to be his successor. And everyone thinks that this guy, Bingu Mutharika, is going to be a puppet of Maluzi. And he looks that way a little bit during the campaign, but not when he wins, right? Starts his own political party, the Democratic Progressive Party. And in 2005, breaks ties with Maluzi and is the only person prior to this 2020 ruling, the only person to have ever actually won a majority of the votes. And he won that in his re-election in 2009. Okay, so he gets to rule the mandate because he wins a majority of the votes. Because Malawi is so fragmented and the parties are so weak that even though the Constitution said you had to have a majority to win the presidency, they never actually implemented that. They're like, plurality, close enough, right? And Bingu Mutharika, during his first term, he implements all these really popular policies like a fertilizer input subsidy program, which along with some really wonderful God-blessed rains in 2006, like took people out of famine for like the first time in a long time. And so everyone credited him instead of like, I don't know, whatever divine being they believe in for the rains, but they've credited him in his fertilizer program. Okay, so then he wins in 2009. Then he's like, I would like to rule for life. That would be nice, right? Oh, can't do that. So, but maybe my brother can rule after. So like, his second term, there's a lot of what political scientists would call autocratization or democratic backsliding, right? This move towards, and there was a lot of corruption. Perceptions of corruption goes up during his second term. And that's consistent with how it was with Bakili Maluzi too, that like something about Malawian presidents in that second term, like don't trust them. Because that's their, I'm sure game theorists could tell us exactly why that happens. Here's the thing. He doesn't invest in health, okay? There are these central hospitals in Malawi. They're large public hospitals, but they actually have some of the best doctors in the country. If I were to get sick, like that's where I would go because they have really excellent doctors there. They're very busy. They're understaffed. The facilities could be better maintained, all sorts of problems. So he gets a heart attack. He has a personal physician. The guy has had health problems for years, but he never sees anyone in Malawi, right? He's one of these African rulers who will go to Singapore or somewhere else to get excellent medical care. So does not invest in the population's health, right, by investing in public health. Okay, I should go faster. And then he gets a heart attack. He gets taken, like his personal doctor's like, I can't fix this. So they take him to Kamuzu Central Hospital, the main public, because that's where the best doctors are. They can't help him either, right? Because he hasn't invested in them. They don't have, also he's very dead by this point. They don't want him to be dead because there's lots of people who benefit from him being president. So they actually like lie for 2 days that he's getting healthcare in South Africa. It's like, Kim, his body is cold. Like he's definitely like, there's also like lots of juicy rumors about that too. I encourage you to check those out on the internet. Okay, so let's talk about health spending and health outcomes. So it looks like health spending goes up and health outcomes get better, right? So the stark line is health spending per capita, that's going up, and under 5 mortality is going down, right? So eyeball test, that checks, right? That good health spending, good health outcome, right? I'm not so sure because child mortality was probably going to go down anyway. I'm not so sure that the health spending was the cause for why that goes down. Also, if we change health spending to what the government is actually spending, right? If health spending was the reason why health outcomes got better, it's not because of government spending on health, right? Because that actually went down. Okay, so I'll skip this. next one. That's me and my kid. Okay, I won't skip it because I have 5 minutes. I can do it. Okay. So this is us at Kayesa Inn in Mchinji, Malawi. I was a young mother when I went to do fieldwork the second time in Malawi, and I took my daughter. And I studied health because she got really sick, and there was like nothing we could do, because with all the privilege that I have as a non-Black person who is an American, right? And there was nothing I could, like, there was nowhere I could take her. We went to the district hospital, which an ordinary Malawian probably couldn't have done this, but I like went right in and I talked to the guy who led the whole hospital, right? And he couldn't help us, right? There was the only way, I call our health insurance and they're like, we show nowhere in Malawi that you can take your daughter to get back. We actually want to medevac you to Botswana. Like and I was like, I'm sorry, I can't believe that. Like, I know that it's a poor country, but there's got to be great doctors here. I don't want to have to take my baby out of the country, right? And they're like, can you drive overland to Zambia? I was like, you have no idea what you're asking me to do right now. I cannot drive overland to Zambia. Like, that's actually really hard to do. So, because I was a Fulbright scholar, I had some weird like phone tree list of random doctors you could call. And because I had money, I could buy up all the airtime I needed to call every single doctor on that list until finally this lovely Southern US gentleman doctor who lived in the capital city an hour and a half away was like, yes, bring her here. It was African Bible College. God bless the African Bible College Clinic. Like, I'm so grateful for them. We went there and we could go there because I had a friend who had a car and I had money to buy petrol. And we drove in the middle of the night, which is actually a really dumb idea. But we drove in the middle of the night to get there and to get her the care she needed. And when we got there, he was like, oh, I didn't know she was this bad. I'm really glad you came. Because he was telling us, like, wait until the morning. Like, it's kind of dangerous to drive at night. I was like, no, you don't understand. My daughter's really sick. And so, like, I pick for you this graph on under 5 mortality because, especially at the time when I was there, actually a lot of children didn't reach their 5th birthday. And, so I think it's important. I would also, like, as a non-citizen of Malawi, me and my daughter, right? I also want to push against this idea of public health that Prince and Marcelin have about how the state should be protecting the care and health of its citizens. Like, why only citizens? And maybe this is because I live in America where we're really upset about people who are not citizens getting access to care and things. And as a person who studies pandemics, I think that that's, even if you want to be a jerk, that's not good for your health if the people who live in your country are not well. So especially if they're not well with an infectious disease. So I wonder if we would even expand this definition to, refer to the duties of the modern state concerning the protection and care of the people living in this territory. Because that's the kind of public health I would want. It's not like, show me your papers and then we can decide whether you get access to healthcare. So thank you all so much for your time and attention.